Okay, madam, thank you. Just I am sharing my slides. This is my screen. Okay.
Okay, so this is like a presentation itself. He is professor and head of Scientific Research Institute, and he has won many accolades and awards. Dynamic Indian of the Millennium by KG Foundation, Gynec Excellence Award at Yuva Foxy 2020, and he has many residents who have trained under him. He has about 8 books published, 3 chapters, 44 papers in IOGR and 5 papers in IJBP, BCP, 536 presentations as faculty in national and international conferences. So we are very pleased to have you here with us, Dr. Manish Bhai, and I would request you to start your presentation.
Good evening, everybody. Thank you, Dr. Nandita. Thank you, Dr. Amita. Thank you, Dr. Archana, for allowing me to share my views on this prestigious BOGS conference. The moment child is born, mother is also born. She never existed before. Woman existed, but mother is something new, said by Radnishji. With the blessings of mother of mine, 3 books written by us is recommended as a teaching material in RCOG. This is Atlas of Petalicocardiography and IVF Made Easy. Both are gone for second edition and available in market. I am editor-in-chief of 2 journals, Indian Journal of Obstetrics and Gynecological Research and Open Access Journal in Gynecology. This is the first one as a keystone speaker. GI disorders in pregnancy. I remember my teacher in physiology who started his GI system always telling that, Manish, how beautifully God has designed everything. If you take a ball or if you take a small food, eyes watching, nose is smelling, and tongue is tasting. Imagine if tongue was somewhere here, eyes were somewhere here, and nose somewhere here, then we have to say, eyes, see, it is good, smell, nose, it is easy to eat, and tongue you have to swallow. So God is very kind. So even though the GI disorder occur in pregnancy a lot, first and foremost, every day, day in, day out, we are suffering from nausea and vomiting in pregnancy. And this happens, we all know, because of the beta HCG. And that beta HCG is changing because of estrogen and progesterone disturbance. And we have got nausea and vomiting in pregnancy. And this is our bread and butter as a gynecologist. It is a common condition affecting almost 85% of pregnant women. Symptoms usually appear between 4 to 9 weeks of pregnancy, and they are usually subside at 12 weeks of gestation. And FC is fortunate enough, it can range up to 34 to 38 weeks also, and we have to give medicine till date. Majority of pregnant women subside between 12 to 6 weeks of pregnancy. About 15% of women symptoms continue up to 12 weeks, and less than 10% suffer till the term. So what are the things we can offer to them? It is also known as hyperemesis gravidarum. Can be diagnosed when woman has got protected nausea and vomiting with triad of more than 5% of pre-pregnancy weight loss. Usually they are very lethargic because of dehydration and electrolyte imbalance. So usually this type of ladies coming in our OPD, and we have to give them the IV fluids. They had done a survey of 808 women who had terminated their pregnancy because of hyperemesis gravidarum. And this happens only in Western country. I had never seen this type of study in India, because here the mother-in-law, the mother and doctors are giving them the proper tender loving care. And till date, I am practicing since last 27 years. Till date, I had not seen any woman they are going to terminate their pregnancy because of hyperemesis gravidarum. But they had done beautiful study, and that study was published in 2018 only, so it is a very recent study, that 800 out of 808 women, 15.2 had at least one termination due to hyperemesis gravidarum. 49, that is 6.1, has got multiple termination. And prominent reason for this termination, their inability to carry the self-work. Here, because of this, our family situation, that everybody is staying together, they don't have to take care as a nuclear family, and they don't bother about their baby care, because here mother-in-law and mother are ready to take care of it. So there are cases in which they are going to terminate because of the hyperemesis gravidarum. What are the risk factors in whom we can see the hyperemesis gravidarum much? Usually they are young, they are primary, obese and lean, there is no difference. Multiple pregnancy, there is increased chance of hyperemesis gravidarum. Women with maternal or family history of nausea, vomiting. If you ask, in first pregnancy they have got the symptom. Second, usually it will less, but sometimes it may increase or it will remain the same. And there is personal history of motion sickness. Those who have got traveling difficulty, they are more prone to get the motion sickness, because we all know that this vomiting is arising from the chemoreceptor trigger zone, and which is very much near to the bones. What is etiopathogenesis of this nausea and vomiting? There are so many factors who has been proposed that includes metabolic and hormonal stimulus, as I already told, because of HCG and progesterone, immune dysregulation, GI motility. We all know there is one hormone known as relaxin that usually gets stimulated when she is pregnant. So all the activity, not only the GI activity, but all the activity of her is sluggish. So there is a less gut motility, and she has experienced the gastric emptying time is more. So if we give them the prokinetic drugs, which will empty the stomach well, then the nausea and vomiting will be less. H. pylori infection and psychological predisposition. If suppose she doesn't vomit, then somebody asks, you don't have any symptom of vomiting? There is a one joke in USA. The mother-in-law is asking from India that how is your wife? He says, wow is okay, che. Then mother-in-law is very happy that wow is okay, che, that is vomiting. But that is not the vomiting. That okay is okay, okay. Not this okay, okay. Okay, so joke apart. The onset of NVP in the first trimester, and if it is initial onset, it usually subsides after 10.6 weeks. That typically starts between the 4th and 7th week of gestation, when their beta HCG is very high. And we all know that after 12 week beta HCG is going down. It peaks approximately at the 9 week and resolves about 20 week in 90% of women. What is the maternal effect of nausea and vomiting? Those 808 women suffering from, they had terminated their pregnancy because of hyperemesis gravidarum. They are worried of vernix encephalopathy, because Google says vernix encephalopathy as a first. There may be splenic avulsion because of great insight into abdominal pressure. Spleen can get avulged. Because of severe vomiting, they can go for esophageal rupture. Sometimes they can go for pneumothorax. And systematic review demonstrated significantly higher depression and anxiety score in women with nausea and vomiting and hyperemesis gravidarum. What is vernix encephalopathy? That is because of thiamine deficiency, classically present with blurred vision, unsteadiness, confusion, memory problem, drowsiness, and on examination there is usually nystagmus, ophthalmoplegia, hyperreflexia, erexia, and there is a, if you tell them the finger nose ataxia, that is a difficulty. Severe abdominal or epigastric pain is unusual in nausea and vomiting in pregnancy, may warrant further investigation of serum amylase level and abdominal ultrasound, and possibly esophageal gastroduodenoscopy, which is considered safe in pregnancy. So if they are suffering from this many situations, we have to take Dr. Mayank's opinion as a GI expert. What is the treatment option available for this pregnancy nausea and vomiting? Usually in India, we do the dietary measurement. Standard recommendation to take prenatal vitamins for 1 month before pregnancy. Small and frequent meal, 1 to 2 hours to avoid full stomach. Usually tell them first take roti and chapati, and after 2 hours they can take rice and dal. So likewise, dietary modification to avoid the spicy food, because we all know that spicy food can give rise to irritation in the stomach wall, and they can give rise to reflux esophagitis, and antiperistaltic activity there, and it will cause the vomit. Always give them the tender loving care option. T, tender loving care, emotional support, everything will be fine. It is a naturally, this is common, this can happen to everybody. Those who are pregnant, they're suffering from nausea and vomiting. So give them the psychotherapy, behavioral therapy, hypnosis may be beneficial in women with severe nausea and vomiting. Nowadays, there are so many companies are marketing their tablet with ginger, and scientifically it is proven that ginger stimulates the GI activity and motility, and inducing a flow of saliva, bile, and gastric secretion. So you see, our Ayurvedic science is very good. They say that if there is a nausea and vomiting, you can chew ginger. That is adu. You can chew ginger inside the mouth and you will don't have this nausea and vomiting. Thiamine supplementation, either oral or intravenous, should be given to all women admitted with prolonged vomiting, especially before administration of dextrose or parenteral nutrition. That usually we are giving MVI in the unit, and that we call it as a Rasnadri. What is the management algorithm for this patient, in which we have to give them the pharmacological and non-pharmacological option? First, always non-pharmacological option. Convert parenteral vitamin to folic acid and supplementation only. We can give ginger as a capsule, 250 grams daily, and consider P6 acupressure with wristband, and that is acupressure also people are giving. What is the pharmacological option? We can give them vitamin B6, 10 to 25 milligram orally. Either they can take alone or in combination of doxylamine. Usually in India, we have got doxylamine subsequent with pyridoxine. So it is available regularly, and it is our custom to give 2 tablets at bedtime and 1 in the morning. Pyridoxine and doxylamine 10 milligram combination product, 2 tablets orally at bedtime and 4 tablets per day according to the patient need. You can give pyridoxine 20 and doxylamine 20 in combination of 1 tablet orally at bedtime, initially 2 tablets per day. If the symptom persists, we can add diamine hydride 4 to 6 hourly, diphenhydramine 25 to 50 milligram, flucarperazine or promethazine to reduce the chances of vomiting. Here I had not mentioned the ondansetron that usually we are giving. This is off-label use, but we are giving Granirax and ondansetron. It gives very good result. And objective and validate index of nausea and vomiting, such as pregnancy unique quantification of emesis score, can be used to classify the severity of nausea and vomiting. They used to give very much score, and yesterday we have got very good conference of endometriosis with new scoring system. So every day they will find something new and new. So hyperemesis gravidarum affects between 0.3 to 2.3% of pregnancy. The condition is defined as uncontrolled vomiting requiring hospitalization, severe dehydration, muscle wasting, electrolyte imbalance, ketonuria, and this we have to find because usually this patient has got serum acetone positive, and treatment of this serum acetone is IV insulin only. No antiemetics will work when there is urine acetone is positive and serum acetone is positive, and she is suffering from ketonuria, and you can smell from the breathing. It is a Kussmaul breathing, and you can smell the ketone in the circulation. So here you have to give insulin only. Most of these patients have got hyponatremia, hypokalemia, and low serum urea level. So we have to supplement with Hartmann solution, that is a ringal lactate. What is the recommended antiemetic therapy in the patients? First line, we can give cyclizine 50 milligram orally or IV 8 hourly. Prochlorperazine 5 to 6 milligram 6 to 8 hourly orally, intramuscularly or rectally. Usually rectal dose is not very much popular in India. Promethazine 12.5 to 25 milligram 4 to 6 hourly orally, IV or PR. Chlorpromazine 10 to 25 milligram 4 to 6 hourly orally, IV or IM or rectally. Second line, we can use metoclopramide 5 to 10 milligram 8 hourly. Maximum we can give for 5 days duration. Domperidone 10 milligram 8 hourly. Ondansetron, now it is used as a second line of treatment, 4 to 6 milligram 8 hourly, and recently we have got granisetron also available in market. So it is a very good drug. Third line, if suppose with this she is not able to control the vomiting, last resort in COVID, everybody is knowing that give hydrocortisone 100 milligram twice daily IV. Once clinically improvement occurs, convert to prednisolone 40 to 50 milligram. This should not be given in first trimester, but risk versus benefit ratio, so we have to consider this when there is a very severe vomiting. Here we can give stametil also. Okay. So management option, IV fluid should be provided to replenish the lost volume, rehydration along with replacement electrolytes for the treatment of hyperemesis. Here we can give normal saline or Hartmann solution are suitable solutions with potassium chloride can be added as needed. While replacing the electrolyte, physician must consider the risk of rapid infusion in order to prevent such condition as central pontine myelonesis. In patient management should be considered there is at least one of these following: continued nausea and vomiting and inability to keep down oral antiemetics. If there is a continuous nausea and vomiting associated with ketonuria and weight loss, despite oral antiemetics, confirmed or suspected comorbidities such as UTI or inability to tolerate the oral antibiotics. We can give normal saline with additional potassiums in each bag with administration guided by daily monitoring of electrolytes is most appropriate intravenous hydration. Dextrose infusion are not appropriate unless the serum sodium level are normal and thiamine has been administered. So, in first trimester, if there is nausea and vomiting, always start ringer or normal saline. Next, after this nausea and vomiting, you can go to the end of GI system, that is constipation. What is constipation? Constipation is a common condition affecting the about half of the women at some point during it is associated with straining, hard stool or incomplete evacuation. This constipation can lead to impaired quality of life. Because of straining, they can develop the hemorrhoids and distress to the pregnant woman. A number of women suffer from constipation prior to conception and find their symptom worsen during pregnancy, and usually in my OPD I can see 1 or 2 patients, sometimes they can go for the finger evacuation. So prevalence of constipation, first trimester 24%, second trimester 16%, third trimester 26% and postpartum 24%. So in all stages of pregnancy, suffering from constipation because of relaxin hormone and slowing activity of her body and enzymic condition. What are the causes of constipation in pregnancy? We all know that there is a progesterone, because we have to thank progesterone because our body or our embryo is nurtured in utero by sufficient amount of progesterone secretion from the corpus luteum and then from the placenta. So this progesterone induces decreased level of motility, which normally stimulates the gastric atrium. Decreased level of relaxin, which is normally inhibits GI smooth muscle. There is a less of physical activity, a less of strenuous exercise. In the food habit, there is less water intake, lack of fiber. We are supplementing her with iron, and there are some part of nausea and vomiting. This all can cause constipation. The effect of progesterone on GI gut, there is inhibition of the gastric smooth muscle, decreased smooth muscle contractility, prolonged gastric emptying and delayed transit. Okay. Metabolic functions are in the pregnancy. There are chances that she may suffer from hypothyroid, hypercalcemia, hypokalemia, and so many times nowadays with cesarean, we know that there is we can diagnose more and more diabetes mellitus or gestational diabetes. So we have to diagnose them, and this is also causing constipation. Increased colonic water absorption because progesterone induced aldosterone secretion and prolonged colonic transit time. If stay more in colon, water content will be lost and this stool become dry, and it is very difficult for the dry stool to pass through this gut. What are the mechanical factors? Physical impedance due to uterine contraction and muscles, gravid uterus always pressing over the colon, fetal compression, pelvic muscle floor dysfunction, usually they are relaxed, colonic disease, sometimes neoplasm or stricture, or pregnancy induced hemorrhoids because of this gravid uterus. There is a hemorrhoids. We are giving calcium, iron and magnesium. This can also cause constipation. So nowadays people are making the iron tablet or iron syrup with some stool softening agent. Next. So risk of factor for constipation in pregnancy. Multigravid logistic regression analysis, they says that if she is more than 35, nowadays we are doing IVF practice, so we are getting more and more lady in the 35 or late 30s. This is due to decline in physiology and degradation of pelvic muscle floor and ligament. Risk of gestational diabetes, high blood pressure and miscarriage. Pregnancy body mass index, prevalence of functional constipation in women with pre-existing BMI more than 24. Diet and exercise, increased protein, fat intake comparison to the vegetable intake. Less physical activity during and after pregnancy can increase the incidence of constipation. Even strenuous physical exercise may actually exacerbate delayed intestinal transit. Other factors like sedentary occupation, nowadays everybody is work from home. Psychological factors, threatened abortion in early pregnancy and constipation history is a potential. Those who have got threatened abortion history, they are not going for defecation. because they have got threat that if they strain during defecation, there will be a threatened abortion. So what are the clinical implications? GI function may get disturbed for a longer in women who had constipation irrespective of mode of delivery. Straining during defecation can damage the pudendal nerve and impair the supportive function of the pelvic musculature. Disturbed defecation can result in development of urovaginal prolapse. That is, we can see nowadays it is very less, but previously after delivery they are straining and we can see third degree prolapse. Cesarean section rate in pregnant women with functional constipation is higher compared to lower other method of vaginal delivery. So those who have got cesarean section, because they cannot, because of this cesarean scar, there will not be sufficient intra-abdominal pressure for the evacuation. So there are chances of constipation. So what is the management algorithm? We talked there is a constipation, then there should be a treatment. First and foremost, we will talk about the non-pharmacological approach. In 50% of cases, if they take a diet with more fiber, lifestyle modification, if constipation is simple, it will go. But if it was recurrent, then we have to go for the pharmacological approach. What is the non-pharmacological? We can give them the dietary fiber, increased fluid intake and moderate exercise. Evidence shows that daily fiber intake and active lifestyle were not correlated with prevalence of constipation. So we have to go for the laxative. Which are the laxative available in market? You can have a suppositories of glycerol. You can have osmotic laxatives like lactulose and sorbitol. Stimulant laxatives like biscodile and senna, and bulk laxative like bran and isabgol. Usually we are worse with isabgol and lactulose because it is not harmful agent during pregnancy. So what are the safety profile of all this laxative available in market? What are the alternatives available? That is lactulose. It's be used in conjunction with saline osmotic laxatives. It is unsafe. Polyethyl glycol, castor oil and biscodile. It is safe during pregnancy. Glycerin, that is senna, mineral oil, which is unsafe in pregnancy, and bulking agents like sodium sulfate. If we talk about compare the lactulose, biscodile, senna, and milk of magnesia, the tolerability is very good with lactulose and it has got very good prebiotic effect. Castor oil is risky and can lead to preterm labor pain, and biscodile used with caution in pregnancy and breastfeeding women. So several alternative available in market with so many different varieties. So we can use lactulose, and this is a very good study that lactulose is poorly absorbed systematically. So there is no systemic absorption. Their use has not been associated with adverse effect. However, the individual might experience such small side effects like bloating and bloating. If we use stimulant laxatives, the absorption of biscodile is minimal as it is poor bioavailable. However, women might experience unsafe side effects such as abdominal cramp with the use of stimulant laxatives, and prolonged use can lead to electrolyte imbalance. So continue with non-pharmacological approach like lifestyle modification and diet, management with safer alternative like lactulose, and episodic management with stimulant laxative. That is the best approach we can give to our patient. We talk about the lactulose. It is a semi-synthetic disaccharide used in adjuvant to circadian rhythm of the colon. What is the properties? Lactulose is not absorbed in small intestine. This is the great evidence when treating constipation during pregnancy, as this present no threat to the fetus. Lactulose also not appear in the breast milk, so we can use safely during postpartum period, and laxative with prebiotic effect, suitable for diabetes, and it is not absorbed in blood. And it is also recommended by FOXI in TOG that you can use lactulose during pregnancy, and you can use lactulose in constipation of pregnancy, even pregnancy, postpartum, and during breastfeeding. This is a very good study. This is a very good study that published for the tolerability and efficacy of 30 ml of lactulose. The study was designed, it is an open arm study with pregnancy with constipation. Only 54 patients they had enrolled. Dosage is 30 milligram per day, BID for 15 ml for 15 days, and 15 days follow-up after completion of the treatment. Results is very encouraging. 89% of women showed improved stool frequency. There is a normal stool consistency observed in 87% of women, and physician assessment, that is improvement was seen in 89% of cases, and 90% of patients were very satisfied and fairly satisfied with lactulose 30 milligram per day. So they confirmed that lactulose is very safe, well tolerated in patient in all trimester of pregnancy. So what is the advantage of lactulose as a laxative during pregnancy? It has got very good prebiotic action. Lactulose improve the microenvironment in the GI tract. Lactulose causes increased growth of endogenous bacteria that are potentially benefit to the host like lactobacillus, thereby indirectly reducing the strength of potentially more harmful urease producing bacteria. It has got detoxifying agent because of laxative action of lactulose, trapped ammonium ion and pushed out of the colon and exerted through the feces. That's why they are using in hepatic coma. In all hepatic disorder, lactulose is preferred drug. Safety profile is poorly absorbed. Ideal remedy for pregnancy and during breastfeeding. No effect on pregnancy or breastfeed newborn since systematic exposure to the lactulose is negligible. So all this study has proven that you can use lactulose safely during pregnancy. Other indication of lactulose, RCOG recommends that lactulose in post-operative management of perineal tear to facilitate the passage of stools. So they are recommending in surgical procedure also. In obstetric anal sphincter injury, immediate and postpartum use, and third and fourth degree perineal tear, they are using for 7 to 10 days to swap the tools. If you see doses of lactulose starting from baby 5 ml and maintenance dose of 5 ml from baby to the adult, everybody can this lactulose from increasing dose of 5 to 15 to 45 milligram, and ideally is 30 milligram. According to their use, they can titrate and they can use lactulose safely. It is a non-habit forming composition. Recently, they have come with gummies, very good strawberry flavor gummies, and it is very acceptable by the patient. You can take 2 to 3 gummies according to your choice, and it is very tasty. They can take, and this lactulose solution is tasteless. Here it is a tasty tablet, and you can take it. Patients are taking happily, and on the next day, gut safa, everything dafa, and they are fine and they are happy. Last thing is GI reflux disease. GRD is reported 40 to 85% of pregnant women, usually beginning at the end of first trimester, and can profoundly impair their quality of life. When present, GRD during the entire pregnancy and usually resolves after pregnancy, and complications such as erosive esophagitis, bleeding or stricture are rarely occur during. This will be very detailed discussed by our gastrointestinal doctor. So just I am highlighting only one slide. What is the management option? Consultant with healthcare and telemedicine we can give them. Conservative management include avoiding eating at the late night. Here, Chow Vihar, there are so many Jains in this forum. So they are advising Chow Vihar. This Chow means Charpaga and Chow means Chandnara. They are going at Vihar. So they are going at home and not eating anything after the night. So we have to advise them to avoid this GRD. Give them the advice of Chow Vihar. If symptom persist, medicine can be necessary. First line of treatment, calcium and magnesium are considered safe in pregnancy. These are the antacid. Furthermore, patient prefer to use medication because it relieves the symptom. No pterogenetic covered drugs has been observed in animal study. Bicarbonate containing agents such as sodium bicarbonate should be avoided as they can precipitate metabolic alkalosis and fluid overload in mother and baby. And there should be a further concern with aluminum antacids, the potential developmental retardation. Now we can say it is a fetal growth restriction. Retardation word is now no longer used in our obstetrics and gynecology. The women take high doses of this medication. So H2 blocker and PPI, histamine type 2 antacids are open text next line therapy. Both cimetidine and ranitidine has been used with excellent safety profile. Although safety concern with proton pump PPI are in recent meta-analysis, Gill et al. Did not find any increased risk of major congenital malformation with PPI during pregnancy. However, some studies in past reported dose-related embryonic and fetal mortality in any study with omeprazole. Now they have done study and it is considered to be safe. PPI are now onwards classified in pregnant women, usually reserved for GERD complication who did not respond to previous treatment. All this agent decreases gastric acidity, should be used with caution as they can lower the iron absorption, and iron is the most common constituent of our prescription regime during pregnancy. So thank you very much. And at the end, our patient should be happy. And this is my common slide.
Thank you, Manish bhai. You have very clearly elucidated the common gastrointestinal complaints in pregnancy.
Thank you, madam. Thank you.
Thank you.
So just I'm stop sharing my screen.
So do we go on to the next speaker, or is there time for any discussion?
Yeah, Dr. Jain has also joined us, so we welcome you, Dr. Pankaj Jain. Dr. Mayank sir, you can share your slides.
Okay, sure, I'll do that. Yeah, is this okay?
Yes, sir.
Am I audible?
Fine, sir.
Yeah. So, shall I then start with the...
I'll just take a minute to introduce Dr. Mayank Kabrawala. He's the Director